Good morning. If I could have your attention. Thank you for being here with us. This is the Appropriations for Healthcare Committee, and I appreciate everyone being here. If I could, Chairman Hawkins, will you open us in prayer?
Would you please bow your heads? God, we come to you today asking for the wisdom and guidance to the healthcare problems and obstacles in this state. Please help us with making the best decisions, both monetarily and through the programs. We ask this in your name. Amen.
Thank you. Again, I appreciate everyone being here today. We are going to be looking at what the agencies do, what your needs are, how successful your programs have been, and just sharing anything that's on your mind with us. To begin, we have our first presenter will be the Georgia Department of Public Health, and we appreciate it. I'll let everyone introduce themselves, and thank you. Please go right ahead.
Thank you, Madam Chair. I'm Captain Tweedy, the Commissioner of Public Health, and it's a pleasure to be here. Sit on Santa's knee, and it was witnessed by the director of the composite board, and he may have pictures, and so I'm going to have to pay him off to not share them. But I've been promised I'll get all my wishes, I hope, for this Christmas. I wanted to start with a reminder of our unusual structure in Georgia Public Health. You're well aware, we talked about this at the study committee, where we have a state office and 18 public health districts. The directors work for the state, and yet the 159 boards of health are independent. And we've actually talked about the fact that you can't even transfer from a county position to a state position without losing leave. I do have an update for you since we last talked, even last week, and that the governor has said we can move forward with a bill to fix that as an agency bill, which is very exciting because that's a problem. We've recognized that the opportunity to advance within public health has been limited because of that, the desire to obviously not lose many hours of leave and other benefits. So we are hoping that with your help we can fix that this session. And then we clearly our goal is to serve all Georgia citizens. Looking at our core public health services, this is a question that came up at the committee meeting. You know, what are the things that every health department should be providing? And it includes everything from immunizations for kids and adults, as well as STD, HIV, TB treatment, family planning, children's services. And I have also in your packet a list of all the children's services we have, because if you look at that list, we have a wide array of opportunities to better help kids get ready for school. One of the issues that's come up in many of the discussions this summer has been around literacy. Well, virtually everything we do, both to improve the health of women prior to pregnancy and then during pregnancy and postpartum, then with the children, the child health services can improve kids' access to and benefits from in school. Some of the other things that we do that you're well aware of are the WIC program, and then the environmental health services, which often raises issues during the session. I neglected to bring my holiday present from staff, which is a cup that says I love septic tanks, because that seems to be what I spend much of my time on. But that is just one piece of the environmental health picture, because we also do lead inspections and other things to improve child health. I wanted to look now at the FY 2026 budget by funding sources, because for those of you who aren't totally familiar with the federal side, half of our funding is federal. And we had even more percentage prior to the rescission of the COVID funds. And so a significant portion of our budget comes federally, and half of our staff are federally funded. And I think what's also not clear from this picture where you see the federal funds is that there are over 150 grants, federal grants that come to us, some as small as $35,000, $50,000, and some as large as WIC with their hundreds of millions of dollars. And all that requires an enormous amount of effort on the part of our budget and finance office, as well as contracts, to get that money out the door. And that's one of the pluses and minuses of federal funding, is that, particularly in this environment, that funding isn't necessarily secure, but also there's quite a bit of paperwork to process that in this environment with so many different grants and sources. The state funding is relatively small by comparison, and more than half of that goes out in grant and aid to the districts. It doesn't go to pay for state staff. And so all of this was kind of background to where I'm leading. And so kind of some takeaways from just looking generally at the budget. Again, 49% of our state funds are budgeted for grant and aid to counties, so it stays, it's not in the state office, but going out to benefits to the residents of Georgia. Half of our budget is federally funded, which funds all those programs you think of as our public health core programs, including nutrition programs, emergency preparedness, the WIC program, health programs for children, and HIV prevention. Moving on to the next two things I wanted to cover briefly. One is about our laboratory. Although this wasn't specifically a question, I wanted to raise it because it's going to come to your attention, I'm sure, particularly as you're seeing the draw for the World Cup over the weekend and kind of what's happening in Atlanta soon with the FIFA activities. You probably aren't aware that our laboratory is very, very intimately involved in a lot of this preparation for the World Cup. And in fact, we're doing preparatory testing so that we can monitor for bioterrorism and other kinds of potential pathogens, even in wastewater, that may come to our attention, because you're going to have an influx of individuals, not just from out of state, but even from all over the world, that may potentially, we may need to do some public health intervention. So all this is going on now in preparation for that event, quietly and behind the scenes. We have two laboratories, one on Claremont, one in Waycross. What I wanted to do today is to invite you to come visit one or both of them, because it's really quite impressive what we do. And I don't see Dr. Burke in the audience, but he and his team have been working diligently on a grant to CMS, and we're hoping that through that CMS Rural Health Grant that we'll be able to even add to the capacity of the Waycross Laboratory as well, particularly in the area of newborn screening. Newborn screening is probably the single most important test we do at the laboratory, and it's the most frequent test being done, touching every child at birth. And many of you have, particularly Chairman Hawkins, knows a lot about this program. It's been in place since the 60s, and I think that we will continue to monitor it closely. And as we are looking at how to do things efficiently and effectively, and looking at other opportunities to address some of the fund sources we could use to expand these programs. As I mentioned, the bioterrorism unit, BioWatch, which is that surveillance system to look for unusual pathogens that may be coming in during this time. And I'll skip over the budget request because we'll be talking about that at a later date, I'm sure. But we are trying to simplify the laboratory budget so that you can look and see exactly how much funding we have in the lab. Much of it's state, but it's spread across multiple budgets, which makes it difficult to really maximize the benefit of the program. And so we're working on that very diligently, including a courier system that will serve all of the districts and counties in a much more efficient, cost-effective way. And we're looking forward to that work, and have been in fact involved with consultants and others, and a new laboratory director who joined us recently from CDC. I wanted to shift now to the home visiting program, which is something you've heard me talk about. What? No, we go. Yeah. We have talked about it at some length. This program really evolved out of the needs identified at a time when many of you came to me saying, what can we do to address maternal mortality in this state? And we had we still have a very effective maternal mortality review committee who has consistently recommended that home visiting be a keynote part of what we do. But in addition, if you look at our numbers for infant mortality, and I have these available if some of you are interested in seeing it, our infant mortality is higher than many states and has remained higher even as we have leveled off for the last 15 years. We have not gotten better. Many of that is our maternal issues, and much of that is due to prematurity and low birth weight. And so many of the things that we are doing within the home visiting really address mother and baby, which was the intention, because you can't have healthy babies unless mothers are healthy and vice versa. And so it's really trying to address the mother and baby, that dyad of the family, as well as the family members themselves, as they call it, the next gen approach to this, to ensure that the family environment is safe and the family environment has access to the services that can benefit all that family if other children are in the household. I think what is really unique about our home visiting program, which was based on the recommendations from the maternal mortality review, is that we use community health workers, often from the very communities, as well as nurses overseeing them. We have what we have done is also combine multiple programs. The federal government funds a series of programs called McVie, which are based on certain efforts to address a subset of mothers or a subset of issues such as literacy. But what we have done is really combine those into a comprehensive approach, including medical care. And so we have already identified women with early preeclampsia to get them to care. We've identified infants whose mothers are fine, although we're at high risk during pregnancy, but who are a threat of a fatal condition that were recognized in the home and able to get care. And I passed out a handout that includes an updated summary, including some vignettes about that. And you may have heard some about the infant mortality, because I think the March of Dimes just issued a report, and it was synchronous with us looking at our own look with our data at infant mortality, and we see that we are addressing those very issues very, very effectively with the home visiting. If you look at your handouts, you see we have the accomplishments, we have the number of women reached, but also to show you with your support and interest in this program and recognition of its value, we have moved from 21 sites when it was initially funded in 2024 to 50, and now 75 counties are covered. You can keep going. I'm talking faster than you are. So if you look at the home visiting expansion, which I have been asked to provide information about by some of you, as well as OPB, our expansion really is needed to be able to provide these critical services to high-risk mothers and infants. And we begin at any point during pregnancy. We don't have a window for which past that window we won't accept you, or vice versa. It's very, very open to those women and children in need. He's fired. I'm sorry. This is my new chief of staff. I didn't introduce him. He's Chris O'Connell. So this is this is his first budget presentation. Will, by the way, is out on paternity leave, so he's not here. But the expansion would allow us to expand to all the counties without an OBGYN provider. And as many of you know, because you come from there, 82 counties are without an OBGYN provider, and 108 counties have no delivery hospital. Again, with a shout out to Dr. Burke and his team, we're asking for additional benefits to be able to, through that CMS Rural Health Grant, to improve the perinatal services at all the hospitals, including with the AIM bundles and the perinatal improvement package. But we don't know if we're going to continue to get that. I'm not talking randomly. I'm really following on this thing. But the home visiting, and this was a specific question asked, what are the home visiting costs? For a county, we can add each county for only about $112,600. You say, how can you do it so cheaply? Well, we do it because we use our teams that are using community health workers plus RN supervising. We have set up the training. Because it is done within public health, we can cross district lines, we can cross county lines, and so we can, for areas with a small number of births, we can double team them across county lines and really provide more services and more benefits with a greater efficiency of our dollars. And that's, I think, what is to me, so exciting about this program. It has such tremendous outcomes already, but it really is very cost effective. It's a bargain if you look at those outcomes on that sheet. And so the total cost to expand to the non-served counties, the 79 counties not currently served, would be about $8.9 million. So at that, I think there were some other questions that had been asked about a number of different topics. I have written those up into a answer form, but I'll be very happy to answer, and I'm already out of time. And so anything else that you need a briefing on, I'll be happy to provide it in writing or in person. And it's a pleasure to be here. Thank you.
Thank you for this very thorough presentation. I would ask, are there any questions by members of the committee? Okay. Please, go right ahead.
Thank you. Dr. Toomey, thank you for being here this morning. One of the things that you all do are the newborn screenings. And with all of this hoopla about what the CDC is recommending, what effect is that going to have for our newborns here in Georgia?
Yeah, let me say, as I think I told you last session when we talked about what is happening, because newborn screening had an advisory committee in HHS, which was eliminated. We have our own committee, which is based on Georgia experts who I trust very much from all over the state, university professors as well as others, including consumers of the program. Very, very, it's to me one of the most important programs we did. I'm of an age when I didn't get screened, and I'm glad that we have this now, because it didn't start until about 1965. So we will continue to look for guidance both from our internal committee as well as external groups like the Academy of Pediatrics, who have, and other groups with expertise in this area. So I don't feel that at this time we are going to have any harm here, because we have so many assets in terms of external technical resources.
So you're saying my constituents don't need to set their hair on fire because of the meeting that they had last week where they're talking about not doing certain screenings?
Well, that wasn't newborn screening. That, I believe, was hepatitis. And that's a different issue. It's about newborn vaccination.
Yes, that is right. It
Yeah.
was about vaccination, but it was for newborns. They were
It's for
talking about
newborns.
the first one.
And I have looked at this issue. I have to tell you very quickly a factoid is that I actually was part of the original vaccine trials for the hepatitis vaccine in the 1980s when I was working for the Indian Health Service. So I actually feel very strongly about the safety of this vaccine. But, the recommendations were made, but the vaccine is still available. Interestingly, public health has not been the ones delivering those vaccine doses. It's been largely hospitals and pediatricians. I looked into that. More than 95, I believe, % of the hepatitis doses have been delivered by private sector physicians, including hospitals, and the vaccine will still be available. I think what our job now is to ensure that every parent who is confronted with a shared decision-making about this vaccine gets accurate information about its efficacy, the necessity in their particular case, and the safety of it.
So how do we do that when there's conflicting information being sent out?
Well, I think that public health it should be a source of good information. I think there are other sources of good information. And I think that is something we are addressing in public health nationwide. And we have to continue to be very clear about where our guidelines are coming from, what information there is. Everybody can't be data-driven if everybody's data are different. And I think we have to be just very clear about what we're seeing and why that is, but also recognizing that parents have a situation that they need to feel comfortable and trust the situation that's presented to them. I think there has never been a mandate to do this, and I think that was part of, and CDC never mandates anything. What our concern is always that the vaccine be available within the Vaccine for Children program. And I've gotten assurances through the weekend from colleagues with the VFC program that the vaccine will still be available, even though there is a change in that guidance.
Thank you. I will tell you, I did a little research on this also, and it is still available. It was just automatically being done at birth. And now,
But you could always opt out, so it was never,
right,
a child
it wasn't
was never,
mandated, but it's almost like it's postponed, or if there's a need, if a mother had hepatitis, and of course they would do inoculations that's appropriate for that time, but they can get it at any time if they need it, was my understanding.
And it wasn't changed for moms who tested positive for hepatitis. But again, what was the value of the vaccine was that it, if given at birth, we have seen the reduction in chronic hepatitis, which is a terrible illness.
Okay. Are there any other questions? I don't see any, and we appreciate your presentation today, and thank you for everything you do. We really appreciate the department. Thank you. Our next presenter will be from the Georgia Department of Community Health.
Which one's yours?
You can do it. No problem. Do you want to put it on the slide? I don't really know how. Come on, man. There you go. Is that good? Is that good? Give me a leg.
Good morning, and Dr. Burke, thank you for being here. If you want to introduce yourself and begin your presentation.
Thank you, Madam Chair. I need some of y'all to smile a little bit. Is this a funeral? That's better. Thank you. Appreciate the opportunity to be with y'all this morning and getting close to the holidays. It looks like a lot of work being done outside to make this place look festive, which we always enjoy. It's a beautiful building. Chair lady sent over long list of questions, and we're going to do our best to answer them all as completely as possible, and but always know that we're available for consultation, answering questions at any time. We haven't worn your hat before. I understand the importance of this effort and exercise, and want to make sure that y'all look at us as a true partner in making healthcare better in Georgia. A few of my team members here. Cody's running the slides for me. He's the young brains of the outfit. Joe's the old brains of the outfit. And I'm the oldest of the outfit. And Emily's somewhere around here, so I think she's hiding. But our chief of staff kind of tries to keep me straight. Our program is complicated, and you did mention for me to introduce myself. Dean Burke, Commissioner, DCH. Sorry about that. DCH has 10 budgetary programs as well as 3 attached agencies. Those will be presenting later, so we don't have a lot of information about those entities here. But DCH is a complicated agency because it does a lot of things that may or may not really have a lot to do with each other. But our biggest area of budgetary interest is Medicaid. We also oversee the state health benefit plan. We manage the state office of rural health down in Cordele, which is important to me with my background in rural health. We regulate the state and federal healthcare facilities licensure, so we license nursing homes, assisted livings, and many other entities. And we also survey those homes for the elderly with our survey team on a contract with CMS. We also manage our health planning, which most of you love or hate, is what we call the CON program. And we also have the State Board of Pharmacy and Dentistry that are attached to our agency. This pie chart shows you the spending. As you can see, the majority of the spending is for our programs of healthcare delivery, which Medicaid makes the largest piece of it. 97% of our funds are spent on benefits, with only 3% going towards operations. Now we've got a lot going on. We have listed a few of the initiatives that are pertinent, but there's many other things that our team works on every day. Constituent services being an important part of that, and Brandy and her team are also supposed to be taking care of y'all's needs. So make sure, Brandy, raise your hand. I think most of them know you, but she's been serving in that role for many years and does a great job. The SHBP Medicare Advantage program was reprocured year before last, and there was a few changes, but it's important to note that the state Medicare Advantage plan for our retirees is not exactly the same as the Medicare Advantage plans that you see advertised on television. Our members are not assigned a narrow network, and they have a very generous benefit program, and it's just important to, when you hear complaints about MA programs, and if you ask them specifically about SHBP's MA program, most providers will say no, they're not in the same bucket, so just want to clear that up. The other thing going on with SHBP is a transition to NADAC pricing, which the pharmacist at the end of the table here was very interested in. We have been working on all the technology that's going to be required to change that payment structure, and we should be good to go by the first of the year. Don't anticipate that the pharmacists themselves should see anything different. They should just hit the button to send a claim like they've always done, and it should go through with the new NADAC pricing. But again, anytime you have technology changes, if y'all hear of any problems with that system, make sure you let me know. Most of you have a direct line to my cell phone, so I'm not worried about that part of it. But our team has done a really yeoman's job to get that ready. That was a pretty heavy lift to have done this fast, but we look like we're on target. The unmed pilot program, I don't know if y'all have all seen the telehealth booth that's on the second floor of the Sloppy Floyd building that allows our state employees to get health care services. That's a very unique technology, and if you've not been there to see it, you should go by there. And we have certainly been looking at how we can expand the use of that technology in our rural grant program. We'll talk a little bit more about that later. The directed payment program, the DPPs that y'all have heard so much about, we submitted earlier this summer, and we're still answering questions with the CMS over that. It's a little overdue, to be honest. Of course, the government shutdown didn't help us, but we really are expecting to hear an answer from CMS on that program any day now. And it's got a lot of interest with our providers. Obviously, the hospitals have a lot invested in that from the standpoint of the program's breadth and depth and providing new funds to invest in things like GME. So we're all kind of sitting on edge waiting for that result, but hopefully we'll hear from that before the end of the year. Now we'll talk a little bit about the Rural Health Transformation Program grant, which y'all have heard about. It's $200 million a year for 5 years grant opportunity from the federal government. We submitted our application before the deadline earlier this last month, and we're waiting to hear the CMS's decision on that. There's an equal share baseline of $100 million a year, and then the next allocation is based on more of a competitive grant process. So we're waiting to hear what CMS has to say. But $200 million a year vested in rural Georgia for the next 5 years is a great, huge opportunity. And our application is very, very, very broad. We did a lot of listening to stakeholders throughout the state. We went to 4 rural communities to have office hours to listen to input, and we had several online webinars for input, and had, when all said and done, probably more than 200. We had 150 before the deadline, but we were getting submissions from people even up to the day that we were hitting send to the application. So we had a lot of folks that had an interest in that and a lot of great ideas. And unfortunately, with that many great ideas, if we would have put everything in our application, it probably would have been closer to $2.5 or $3 billion, which was way beyond the application scope. So, like in everything else in our world, some folks are going to be disappointed that their idea might not have made it to the finish line, and we don't even know yet what the CMS will approve. They have almost like a line item veto possibility. If they don't like an idea, they can just scratch through it. So we'll all wait it again on that answer from them. Going back to other things that we've been working on, we've had several state plan amendments that were a part of legislation passed last year, and all of those have been submitted to CMS. We're waiting on approval. We did get approved for one of those, the CCBHC, the Behavioral Health Center, which should go live first of the year. Those of you that have a special interest in behavioral health have been anxious about getting that out the door. And it's the same for the Qualified Residential Treatment Program. So this is another basically option for us to have for these young people who have severe needs that are not being met, whether that's inpatient or outpatient. Another program that we're really close to announcing the first award is the PACE program, which is the all-inclusive care for the elderly. It's an outpatient option for people who are qualified to be in a nursing home but want to try to stay at home. It's a great program that many states have already enacted, and so we had a lot of good input from other states and from the National PACE Association to make sure that Georgia's program will meet our needs, and that's something that Joe in particular and Brian in our policy shop have been working really, really hard on for the last couple of years, and we'll be excited to announce that soon. We did the partnership with public health in the high-risk mothers with the outpatient monitoring. I think that was a great program. We've had a lot of learnings together, know a little more about what works and what doesn't work, and look forward to continuing our close partnership with Dr. Toomey and her team on all things public health, but especially with my particular interest in maternal health and neonatal health. We have a special approval that we're waiting on from CMS for what's called in lieu of services, and that's where we can use the CMOs, the managed care companies, to provide some services that are may not traditionally be in their capitated payment program, and we're focusing that on the problem that we have with hoteling and young people waiting in emergency rooms for placement when they have severe, significant mental illness. And so we're anxious to get that approved so we can open up that program, which again, along with the next thing I'm going to mention, which is called the therapeutic care model. These are things our behavioral health team have been working on. When Commissioner Noggle was there, she asked me to work with our behavioral health team on identifying these gaps that are causing us to have these challenges with people waiting in the emergency room or having to be in hotels for severe mental illness without a place to go, especially, like I said, in young people. And we have done a lot of work with y'all's support over the last 3 or 4 years to start approving programs to kind of plug in those gaps. And I think we'll start seeing some of those results in the next year or two as these things go live, so to speak. The therapeutic care model will serve youth that will also help us to keep people in our state. Right now we don't have enough beds for severe, complicated youth, especially in the autism space, and we're certainly working hard to try to fill those gaps. And finally, as far as things that we're working on, as those of you know, the One Big Beautiful Bill Act, or H.R. 1, had a lot of changes to community engagement for Medicaid, and it is going to require eligibility and technology changes in our system. And we're still waiting on final rules from CMS on that, but it will be something we'll have to bring to the attention of the appropriators, because there will be some additional funds that we'll need to try to meet those new requirements, part of that bill, before 27. Some of the things go into effect in 28, but a lot of them go into effect in fiscal year 27. We'll move on to the state health benefit plan. There were several questions asked about that. This slide's a little bit busy, but the area on what's on my left side, the member rates, as most of you know, healthcare cost inflation is still a real significant issue, and so the state is fully paying its way, so to speak, on healthcare costs. We're the payers that we contract with basically are just managing the process. We pay all the bills. And so as the cost of health care goes up, those premium rates for our state employees and retirees have to be adjusted to keep the plan fiscally stable. And so these are the rates that went into effect late this year for the next calendar year for our SHPP members. And the slide on the right gives you some outline of our membership. Obviously, we have a very, very large state health employee plan. It's one of the largest on the East Coast, and our leadership in that area do a great job to kind of stay on the cutting edge of making sure our state employees have one of the best state health benefit plans available to help with our recruitment and attention of our state employees. Next slide. This is just a bar chart showing that basically that our revenue does outpace our expenses, which is what obviously is required in our world. We can't not pay a bill. That wouldn't look good to our bond ratings. So we are especially proud to see that in 27, with some adjustments that you guys have made in appropriations to make sure state health benefit plan is fully funded and can meet our expense requirements. And this is just again, another busy slide, but just making sure that y'all understand that there's two sides to our OPEB requirements. The school system is separate from the state employees, and this just gives you some sense of the OPEB liability, and there's still some work to be done on the school system to get that to where it needs to be. Cody, anything I need to add? That's more of your area of expertise. Yeah, we're fully funded, our liability on the state side, but got some work to do on the school side. Chairman Hatchett knows way more about this part than I do. We've had some questions about GLP-1 utilization. Obviously, that's a very popular medication that's been in the news for the last several years, and as you can see, the growth of that use in the state has been exponential. On the left, you see we've got over 40,000 prescriptions as of September, and over I think it's $38 million in that month being spent on that one drug class. This slide doesn't include our rebates that we get, so there is some cost savings that come in later. Those rebates are after the fact, but we do get some monies in from the drug manufacturers to offset some of those costs. But it's still a huge hit to our budget, and because of that, we are implementing a kind of a care management bundle on GLP-1s going forward after the first of the year. This is something I've been very interested in. As a physician, the data tells us that if you don't have lifestyle changes and you use a GLP-1, as soon as you stop it, you've gained nothing from the whole process, and you've spent a lot of money for nothing. So we're going to kind of wrap around some services so that if you're getting a GLP-1 in the future, you will need to comply with some coaching and at least listening to some suggestions on how to change your diet, so that we can see what I'm hoping to be a huge improvement in our long-term health costs. Because if these things are done right, it's almost like a miracle for some people that have severe diabetes, and their blood sugar gets under complete control if they lose the right weight and they exercise and do all the things they're supposed to do. We can significantly lower some of that projection of increased costs in health care. But it doesn't come without some training and coaching that we don't feel like is being done right now. A lot of people are just getting a prescription and walking out the door and kind of on their own. And so we're going to do that, and you may get some phone calls from some people that say, I've got to do something I didn't have to do yesterday, but we feel like it's the proper thing to do for the state and for those members, to be honest. We did also get a question about Trump RX that's been discussed with the president trying to kind of rein in drug costs and not pay more in the United States than our friends overseas are paying for the same medications. And it's important to know that that's not actually operational yet, and it doesn't really affect the states. But we are looking into all of those initiatives that are out there to try to get a control of prescription drug costs. Our pharmacy director is, I think, one of the best in the country at evaluating what's going on in the world and helping us to make the right decisions about prescription drug management and trying to be on the cutting edge when it comes to the use of the right prescription at the right time and hopefully at the right cost. Now we'll talk a little bit more about what might be just traditional budget stuff. This is the layout of the members of our different programs. The low-income Medicaid is the one that the majority of our people fall in, and that's the women that are pregnant and low-income children. Although it's the biggest in numbers, the ABD population, which is 18% of our total count, because of the severity of their health care needs, it actually costs us more money. And as all of you know, the low-income Medicaid is under our CMO managed care program, and our ABD population is still in fee-for-service, although with our new procurement that is under protest that I can't talk about today because the lawyers told me I can't talk about it, that will change some of those programs to bring some of those ABD populations under managed care. But we don't really have a good timeline on when that will happen. Now, Medicaid enrollment, if you can see on this slide, has actually trended down since the pandemic and then the redetermination process where we had to evaluate everyone's eligibility. We think it's calendar year, and then towards the end of this next calendar year and into 27, we think there'll be a slight increase in growth. But those are projections, and if we have a severe recession that comes in, those numbers will go up. If our economy stabilizes and our fiscal health is better, then those numbers may go down. That's just the nature of Medicaid eligibility when it's all those decisions are based on people's income. But again, we do have a couple of million people on our program, so it is a big number, which is represented here in this slide. Those projections are from late summer, September, 1st September. We'll be reevaluating this at OPB's request before the end of the year, and we always give them a updated projection that is real time as possible before session starts. So they'll get some updated numbers, we hope, in the next week or two. Next slide. We had several questions submitted and a lot of discussion over the last year or two about Medicaid fraud, waste, and abuse. There's been several high-profile cases that have been published, one in particular recently in Minnesota. And please know that we take our oversight role very seriously. Our Office of Inspector General has many programs, both audits and third-party vendors that we use to try to make sure that we can't eliminate criminals from trying to gain the system. That's impossible, but we want to catch them as quickly as possible using advanced AI and analytics tools to identify things that just don't look right. And we've had a lot of success over the last couple of years pulling back money or changing the eligibility to the right way when we have people who are getting paid for Medicaid payments both in Georgia and in another state. So we have a process in place to make sure we catch those and take those off our rolls once we verify they're no longer living in Georgia. But it's a constant battle, and again, not going to read these numbers out to you, but we've, I think, have very aggressive program to try to eliminate fraud, waste, and abuse to the degree possible, or at least to catch it as early as possible to make sure Georgia taxpayers are protected. And as I said, we also have the audits that State Accounting Office manages every year in our program. Next slide. This just some of the, again, the costs that we had some question about what are we paying in claims, and on the left side it's the behavioral health care cost for the past year, and then when we talk about claims, those are based on ICD-10 codes. Chair Taylor, I know you know a lot about that with your real-world business. So we just did the top 10 service areas so that you would have an idea of where those are, and we can certainly provide more in the weeds details on claims as you need them. But these are broken down into fee-for-service and what we get from the CMOs. We don't pay CMO claims. They pay their claims out of our capitated budget, but this is a compilation of what they tell us they have spent on those areas. And again, this is going back to our normal budget slide that shows the growth in our cost this next projected fiscal year. And as you can see, we've had a significant increase in the ABD population, but we did have see some savings in the low-income Medicaid. Our projections on how many members we would have at the beginning of this next fiscal year was a little high, so we'll reflect those savings. And as I said, when we have update those numbers in the next couple of weeks, that savings may even increase a little bit. Chair Lady, I'm finished with the prepared slides. I've got a lot of brain power over here, though, if y'all have questions.
I would say there's a lot in here. Thank you very much. This was a very, very thorough report, and I appreciate that. There is a lot going on with healthcare, and there's been a lot of interest in it. And let's see, do we have any questions from any of the members? Go right ahead, Lee.
Thank you, Madam Chairman. Congratulations, I guess, on your new position. Or how you feeling?
Condolences.
Condolences, that'd probably be better, yeah.
No, I'm proud to work with this team. I've gotten to know them over the last couple of years as the Chief Medical Officer, and we've got a great team of folks who wake up every day trying to make Georgia healthier and better from a fiscal standpoint as well as a healthcare outcomes standpoint. And
Well, I want to start off with my old profession, and that is dental with the ABD. You know, we had an issue when these patients were moved to the limb-type system through that waiver, I believe, and we lost a lot of the providers that were not Medicaid providers. The reason being that ABD patients are much more involved, a lot of times need to be sedated, takes a lot longer to treat these patients, more complicated type procedures. Do we have a patch or a fix we're looking at in the future for these patients?
I think that we've had a carve out. Do y'all want to discuss that a little more? Go ahead, Joe.
We can get you some more information on that. My understanding is we've gone back and we've made an adjustment in the waiver to go back so that we can address the waiver population where we have that higher need in a similar fashion to how we were doing that before we added dental benefits to the state plan.
Right.
So my understanding is, I don't know if that's totally resolved, but that is our current strategy to address it.
So when is that going to be enacted?
I believe that's already underway, but I don't want to speak exactly a timeline. Emily?
There may still be some, we've got to talk about, I think there may be still some legislation, but we will bring that to you on just
Great.
how to apply and what that would take to apply. We've had a lot of discussions, and we plan to meet with the Georgia Dental
Yeah.
Association, but we will let you know because there may be required some legislation during the session for
Okay.
that.
Okay.
And that was just a, unintended consequence of adding dental benefit to the plan.
Right. I knew that was
Once we
not-
do that
Right.
statewide, that's where they have to go. And so we're going to have to do some juggling to make that happen. But I haven't taken care of patients at our state hospital before it closed. I mean, there really is no body that is arguing that those folks take a lot more time and complicated to take care of, both dental health and their regular health care.
Thank you. Another question I had is on United Healthcare. This is coming from my area, Northeast Georgia Medical Center, which are still out of network with United Healthcare, and in the process of buying Longstreet Physician Services, Longstreet Clinic, which is the largest Medicaid provider. Thereby, any child or anyone that has United Healthcare will be out of network with that clinic. Are there any workarounds that your department can see? Maybe contracting or allow contracting with one of the other CMO providers for these patients?
There's been a lot of discussion on what to do about that. I mean, we are limited in that contract is between the payer and an entity. It's not our contract, so we can't take that contract over. But we certainly can evaluate the situation to try to be sure that our members have access to care, and we'll take all legal avenues to try to do that, and have been doing that or trying to over the last year or so since that contract
Is it possible
expired.
to maybe have a second open enrollment? Has that approach ever been looked at?
We'll entertain any suggestions on what. Again, we'll have to work with the governor's office and OPB. Anything we do, as far as that is going to have a significant administrative expense, and so we just have to make sure we balance those things out with y'all's help.
Okay. Last question. My understanding is that the foster children in that program is a single contract with United Healthcare. Is that correct? Or do you know? I've been told that.
You're talking about in the future?
Presently, if all foster children receive their health care through United Healthcare?
No.
That's incorrect.
That's incorrect.
Okay.
It's AmeriGroup has that contract.
Okay. Who does?
AmeriGroup, which is
AmeriGroup.
part of Anthem.
Oh, okay. Bad information. Okay. Thank you very much. Appreciate it.
No problem.
Representative Hughley, you have a question?
Thank you, Madam Chair. Thank you so much for the presentation. I'm going to ask this question, but we probably need to talk about it offline, but I have to ask on behalf of my school board. They're concerned that non-certificated persons spend an extraordinary amount of their income trying to meet the health requirement. And so their ask is, can we take them out of the program and let them either go through Medicaid or some other entity? So that's the question. And you can get your team to talk to me about it later.
We'll be glad to. You know, it has been a issue that we are hearing about more in the last couple of years, but there's also the stability of the program to keep it at all. We've got to make sure those liabilities are met. So, you know, look forward to those discussions with the House and the Senate and Governor's office to see what we need to do to deal with that. I think the Governor's office has a plan, and you know, I'm sure y'all may come up with something different. So we'll be glad to. We try very hard to do what we're told here every day. So.
Okay. Chairman, excuse me, thank you. Representative Seaball, you have a question?
I do. Thank you, Dr. Burke, for being here, for your comments. I, too, am a big fan of the GLP-1 drugs, and I'm glad to see that our population is using them. Are there metrics? Do you have metrics in place so that we can measure, like demographic metrics of who are taking those? Are they diabetics or taking them for obesity, as we move further down the line to make sure that we're measuring the impact on that?
Well, there is. Now, the thing about those medications is the benefits on a longitudinal basis it takes a long time for those to have effect. So if a patient gets on them now, the weight loss is, if they do it right, is gradual, and it may be 2 years before they hit what's considered their goal weight, and then over that time their other health markers should improve. So in theory our costs could go down, but we haven't been using them long enough to make what we're seeing now statistically significant. But yes, it's a very, very important thing that we're monitoring, and this new program that we're starting next year will even give us more insight on data points, because we will be able to get the information on kind of the sickest of the sick, the one that needs them the most, to get you know, maybe even weekly data to back whether it's blood pressure or blood sugar and those kind of things, so that we can get a much better idea of what's working and what's not working.
Yeah, over the past couple of years, I've seen significant results. I think you can walk around this Capitol and tell everybody that's on the shot. I'm going to get some T-shirts that say addicted.
No
to the
comment
shot.
about that.
But I'm a GLP-1 taker for diabetes, and it has significantly changed my health for the better. So
I really think, from just my putting on my scientific hat, that it is up there with penicillin as far as breakthroughs in health care. But as I said before, if it's not used and monitored properly, and you don't have all the other supports around it, then it can also be a huge drain on our budget with no benefit. So it's a two-edged sword.
I agree. I think the downstream savings will be huge if we manage that correctly, and I'm glad to hear that you've got metrics and the nutritional in place for that. My second question is Medicaid enrollment. Are we making progress on that, or is the media not doing a good job of reporting that?
I'm not sure which area of enrollment are you?
Well, it seems to be that a lot of people don't have access to Medicaid enrollment, or that they got left out, and I don't believe that personally, but I just want to hear that we're doing everything we can to get eligible members enrolled in the Medicaid program.
Yeah, we would partner with DHS. We manage the finances of the program, and they hold the eligibility type process in their shop. We work with them, almost daily trying to make improvements. One of the barriers, of course, is we've been trying to implement technology improvements over the last 5 years with our enterprise eligibility system, if I get that right. And, the procurement process is bogged down in the courts. And we had some important pieces that need to be implemented to make that process more streamlined and simplified that we're, having to go back to ground zero and start over again because of the challenges with procurement process. So it's really hard to improve something that's kind of outdated, but we're doing all we can and have made a difference. I think the numbers over the past 6 months of the folks waiting on an application to be worked has dropped a significant amount. It's still got room for improvement, and we're certainly supportive of anything that DHS needs to try to make that process work better. As y'all hear from those folks, they've got some real needs, and we need to support them to try to get those numbers down, because it is important for us. When people don't hear from their application in 1 month, they submit another one, and they don't hear from that. So a lot of the numbers are same people. They got 3 applications in the queue because they haven't heard. So we have to work on it. We got to do better.
Well, if there's anything we can do to support that, let us know. I appreciate your team's effort. And also, I just wanted to publicly thank you and your team. I met with them over the summer in relation to some school nursing programs that we're evaluating right now, seeing how we can enhance those programs throughout the state for better health care for our students, more efficiency for our school nurses. And I really appreciate Joe and your team meeting with us, and look forward to continuing those conversations and see how we can improve that program. So thank you very much.
Well, that's really important to me, having sat in y'all's shoes, that we have an open door policy and as I call it, conversation. I mean, we can all make each other better if we listen and find out what our issues are and work together. We got limited resources. I mean, I could do a lot with twice the money, but I realize that's not reality, and so I want us to do the most we can with what we have. And if anybody has an idea to improve the system, then we're all ears. We don't think we have all the answers, and we've made a conscious effort this year to spend more time talking to other states to see what might be working in their states that we've not tried here before. Our team has been in D.C. probably more in the last 2 years than ever before, because that's where our federal partners are and where a lot of decisions are made. And I think we're getting a lot more up to date on where they are going, which helps us to kind of predict where we're going, and it makes the whole thing work better. We're committed to improving things, but we also need your help and support, and frankly your prayers.
And our money.
Absolutely.
Thank you very much.
Thank you. I have just a couple quick follow-up. Again, I will share with the committee. I've asked for information from Georgia Access, the insurance department, to see how their enrollment is going. I haven't gotten that yet. And to follow up, I know we've had some delays with the CMS and approving some rate increases. One of them with the neonatal, we have some increases in reimbursements. Are those moving along, or we're still waiting for them?
They are.
Okay.
Yeah, I mean, I think we're waiting on that last neonatal adjustment that we supported from public health,
Okay.
that we can follow up on where it
Okay.
is, but I think it's in CMS's hands. But
And a couple follow-up to finish up with was the graduate medical education. I know you've worked very hard, and we're starting to see some increases in our rural, and I want to just really thank you for that, because it has been needed in rural Georgia, and they're starting to show some progress. So thank you for all your work there. And I've had a recent inquiry on CON and rural health and some of the heart services in some of our rural. Are they moving along also looking for approvals?
Well, the one in particular, the mutual friend of ours that's
Yes.
trying to start a new program.
Okay.
We're working on that issue. There are some challenges on meeting certain quality criteria that we're trying to work through. So it is a ongoing discussion.
Okay, it just seems like the CON, everyone thought, well, it's gone. It's not gone. We still have some strict rules that you have to have
Yeah.
every I dotted and T crossed.
Yeah, and what we're doing is we do have, as part of the CON reform legislation, we have technical advisory committees that are underway now, trying to update all these criteria, but it's just going to take some time for those experts to meet and come up with the recommendations for us then to put in place. So it is a moving target, but that particular issue we're meeting on this week, to be honest, to try to see if we can get to a resolution.
Well, I want to take this opportunity on behalf of the committee to thank you and your department for all that you do. You cover so many areas, and it's greatly appreciated. Thank you.
Thank you.
Thank you very much. Our next presenter will be the Georgia Board of Healthcare Workforce. You would come forward and introduce your team? Be great.
There it is. All righty. Good morning. Good morning. All right. Well,
Welcome, and please begin your presentation.
thank you, Chair Taylor. My name is Chet Basine. I am the Executive Director for the Georgia Board of Healthcare Workforce. I have been in this role for 3.5 years, and it has truthfully been an extreme joy. So I want to say thank you for having us here today. I'm also joined with Alex Moses, who is to my right. She's going to actually present the first set of slides, and then I will present the second set of slides. But before she begins, I just want to extend my thanks to a variety of folks. And just for context, everyone knows that we are a small agency. Alex will get into the details here in a moment. We are just a staff of 10 and a board of 15 individuals. And our administrative portion of our budget, meaning of the total dollars that are appropriated, the administrative portion that pays salaries and cell phones and Xerox copying machine and all that stuff, is less than 2% of all the dollars. We really do pride ourselves on efficiency. We are constantly looking for ways to make life more efficient. We have worked to digitize a lot of our processes, including loan repayment, which I'll talk about after Alex. So just for reference, that's kind of who we are. And I do want to extend our thanks. There's a lot of people and a lot of groups that we rely on to conduct the work that we do every day, including but not limited to the Governor's Office, the General Assembly, OPB, Staff and Board, GDAC, DCH, because we are administratively attached to them. I do want to also provide recognition to the Georgia Composite Medical Board, the Dental Board, and Secretary of State within the healthcare licensors that we work with. Without all of those folks, at a minimum, we cannot do what you're about to hear that we get to do every day. So with that, I want to say thank you. Ms. Alex Moses, who is our External Affairs and Program Lead, will guide you through the first half of our presentation.
Well, good morning, everyone. It's great to meet you all. This is my first presentation, so I'm very excited to be here with you all and appreciate you guys inviting us to present. So on your first page, you will see the agenda for our presentation. So the Georgia Board of Healthcare Workforce's mission is to identify and address healthcare workforce needs with an emphasis on underserved communities across Georgia. A little history about us is that we originally started in 1976 as the Joint Board of Family Practice, and our mission then was to increase the number of family physicians. While in 1999, the agency became the Georgia Board of Physician Workforce, and afterward, dentists, PAs, and then APRNs were added under our board's jurisdiction. So to reflect that inclusive nature, and we received a new name in 2019, we are now known as the Georgia Board of Healthcare Workforce. Our board is comprised of 15 members appointed by the governor and confirmed by the state senate, and that includes practicing physicians, hospital executives, health providers, and consumer members. And a couple of our responsibilities and our purpose include, addressing healthcare workforce needs across Georgia's communities, supporting GME programs, increasing the number of physicians and healthcare professionals across the state, collaborating with diverse healthcare education programs, communicating with various members like yourself, producing data reports which analyzes the supply and distribution and trends of Georgia's healthcare providers. We also administer loan repayment program, and we are administratively attached to DCH. The next slide just tells you a little bit more about our programs. And last fiscal year, we had a number of accomplishments, but I'll just highlight a few for you. So we administered multiple competitive grants, which were all oversubscribed. We offer nursing schools grants, which we awarded 8 all across the state of Georgia. And those help with programs that have wait lists so that they can graduate more nurses for the future. We awarded 3 GME exploration grants, and we awarded 10 for one time only on the South of State Route 540 GME, 540 GME grants, which that plans to expand or create startup GME programs in Georgia. I also wanted to say thank you for your support for enacting Senate Bill 130, which allows final year residents and fellows to apply for our loan repayment programs. And lastly, we awarded over 170 loan repayment recipients, so that includes providers that give back to our community in Georgia. And I will go ahead and pass it back to Chet.
Thank you, Alex. So the next few slides is going to be some data, just some ideas that when we were first invited here, that we were asked to bring over ideas just for your all's consideration. So the first slide, you'll see this, it's titled Workforce Surplus or Shortage Physicians. What this is from those 4 specialties, the theme of the 4 was physician specialties that an adult, presumably somebody who is at or near Medicare age recipient, would likely need at some course in their lifetime at that juncture. So that's how these 4 were selected. We did all this work over the past 12 to 18 months, so the data is fairly recent, and we did do it with a third party who has access to databases that allows for us to look at billings and do representative samples. So what I will do is just show you using the rheumatologist group up top on how to read it. I know you all know what these mean, but there were just some different interpretations, or I shouldn't say different, but the interpretations, assumptions, and definitions that we use. So FTE, that does not mean we have 101 rheumatologists in the state. It means that we have the equivalency working of 101. You could have a rheumatologist that is retired, you could have one that's working part-time, and all those different combinations. So that, by going into the billing database, we did some, our third party, I should say, did that, how do we say it, like assumptions and calculations on, we might have 30 rheumatologists that all work half-time, but based off of their billing activity and what a regular rheumatologist would do, that is equivalent to an, we calculated it into an FTE. So that is how the FTEs were calculated. When we did this calculation about a year ago, it's saying, given Georgia's population, we are about 4% under what we should have. And then moving on to the third column with the 10-year projection, at the current rate, now there was an assumption using age and just general time when people retire and the amount of net new rheumatologists that tend to come to the state of Georgia, so there's definitely a lot of calculated assumptions in these figures. In 10 years, we would be about 19% under the amount of rheumatologists we would need in this state. What we do know is the median age of a rheumatologist when we did this was 51, and the percent that were greater than 60 years old is 33%. So that level of logic, and that was a multi-month endeavor with the consultant that we used. It wasn't a one-time deal. It was quite invasive in a very good way. What you will see, the theme is that in current status, except for the endocrinologists, we are below target. But with the endocrinologists, we will dissolve that surplus at the current rate of those who become newly minted endocrinologists, those who retire in 10 years, that will be gone. So that is how to read that slide. The next slide, similar but different. The theme here is mother-baby. We did the same thing with pediatrics and OB-GYN, really on the OB-GYN side, focusing really on baby delivery and infants and all things in relation to mother-baby. And what we do is we have the same thing here. We have the FTE equivalent, again, accounting for part-time, retirement, and all those various calculations. So you'll see the FTE equivalents. You will see that the current status is that we are well below where we should be. And we knew that going into there, we just didn't know how far below we were, so that was probably the takeaway. The 10-year projection, that is where we did this a little bit differently, because this was done after the previous 4 specialties you just saw. In 10 years, the way to read the pediatrics one is that 76 figure that you see represents, we need 76 more above and beyond the general rate of those that we are creating or putting into the workforce to maintain our current level. So these numbers really do look a little bit worse, I'd say, than the previous set of slides. We took that different interpretation, and then you close out with median age and percent greater than 60 in the workforce. So this is what we have at the physician level. We are very early in the journey. I will tell you that we are extremely early in the journey, so I don't have any data, but we are doing the same level of analyses right now with the theme of the hearing workforce. So that would be ear, nose, and throat, the ear in the ENT world, audiologist, hearing aid dispenser, and hearing aid dealer, I believe, or licensed dealer, I believe was the last one. So that's collaborative with the medical board and the Secretary of State. So hopefully we'll have that for y'all sometime in calendar year 26. Now I'm going to move on to the dentists. The dentists also have a shortage. For reference, we have about 30,000 physicians in Georgia and about 6,000 dentists. My favorite dentist is to the right of me at the moment. And of those, we have 14 counties that meet the U.S. average, I should say, of 60 dentists per 100,000 residents. The way to look at that on the map, it's the darkest green color that you're looking for, that really dark green, but there's only 14 counties. Georgia does have a little bit older than average, than the average in terms of the dental workforce. You'll see the makeup right there. So with 25% of them are 55 plus, 31.5 are 50 to 64, and 6.6 are 65 plus. There are dentists who are retired that keep their licenses open. So we have raw numbers. What we are doing, thankfully, to the Georgia Board of Dentistry is we are currently in the middle of a workforce survey with them. What that allows is when the dentist is now, when he and she are renewing their license, they then indicate how much of their time is going to dentistry, if they are retired, are they clinical, are they part-time administrative. So we do know that the FTE equivalency, once we calculate it, will be lower than the total licenses. We just don't know what that number is, but we will have that fairly soon, and we're glad. And we will know a lot of other things with that survey. Thoughts or that from the agency to y'all that I would like you to be aware of is that corporate dentistry, known as dental service organizations or DSOs, Georgia is a popular state for those entities. Think Aspen Dental, that's just a big name that comes to mind. That might be where you live or where you drive by, but they're one of many. Those have multiple types of arrangements with the dentist, but it is a corporate dentistry, and it is projected to increase significantly as we close out this decade, which does impact how new dentists go into practice. I do want to recognize that we do have the new dental school coming online, but once the school is online and has 4 years to graduate students, that's when you will start to see that impacting the workforce. And then you have 80% of dentists who are general practitioners. There are other specialties, where you have orthodontics, endodontics, periodontics, prosthodontics, oral maxillofacial surgery, and I believe there are some other, I think there's dental pathology as well, and then there's one within like dental devices. So dentistry constantly is evolving. You will, just like you see with the physicians, seeing it kind of spread out where less and less likely over the long term we'll be doing general practice and be trying to get into more specialties or niche areas. So that is our presentation for dentistry. I do want to talk about loan repayment. As Ms. Moses mentioned in her presentation, we do about 170 loan repayments per year. We are towards the end of FY26. We'll have those announced in January, but we're looking at about 170 again. We do it for physicians, dentists, nurse practitioners, physician assistants, nurse faculty, those are nurses who teach nurses, and then a slew of behavioral health, so psychiatrist, psychologist, social worker, therapist, nurse practitioner, so it's a variety of licensures within the behavioral health family. Just a couple thoughts from me to you. Maybe consider multi-year funding for APRNs and PAs. The physicians and dentists already have it. We do multiple awards for both licensure families, and actually it's looking very likely, it's not final yet, but it's very likely that the bill the governor signed, SB 130, that allows final year residents and fellows to participate in LRP loan repayment programs with us. We are going to have a few winners this year, so that's exciting. It gets them straight out of training and into a community, and that's 50,000 in terms of the population of that county or less as of the 2020 census. Another idea perhaps is allow funds for not just loan repayment but clinic expansion, but not construction, meaning perhaps diagnostic tests that people in certain communities might not have access to unless they drive 2-3 hours. Something that early detection perhaps could save an expense or and or enhance life quality. So that's just a thought, and of course that would all be prefaced on Medicaid participation. So that's what we've got from loan repayment. And then from the physician pipeline, there's a lot going on this slide. So I'm just going to go real slowly to make sure I do a good job. So first is obviously the goal is keeping graduating residents in Georgia. That's our job, that we got to look at things through. One thing I want to point out to you is that second bullet point, fellowship slots. So every year around March to June, we send out a survey. It's been fully digitized over the past couple of years, and it has been a huge improvement. But we send out a survey to every GME site that we have funds appropriated for. They actually have performance clauses, or I should say performance thresholds, that if they don't hit, then their funding could be impacted. everyone, for the most part, had awesome response rates, so it's been great. So we get a really big N, so we know the data is good. That's why I mentioned that. But the number 2 reason, and it's a close number 2, is why are graduating residents of those finishing their residency leaving Georgia? 19.7% leave due to fellowship slots, not having enough here in Georgia. A lot of focus has been on residencies, and they're very important. That's the next step when you finish medical school. But a lot of other physicians or training physicians do move on to fellowship. And think of someone who's done 3 years of internal medicine and now wants to be a endocrinologist, or maybe they did pediatrics and now they want to be a pediatric specialty of some sort, or so on and so forth. So we know that that's the close second to family, and family is 20.9%. Very close. We know the total N on this is about 900 to 1,000 responses, so we're not talking a lot in terms of raw number. It's like 10 people of a difference. The next bullet is the in-state match rates. So those are the 5 medical schools here based in Georgia. You will see the percentage per our annual survey. We do also administer surveys to graduating medical students. We tend to administer that around March, when they've figured out their match results and they're pretty much near the finish line of their medical school journey. We then know who in Georgia is going to which Georgia residency programs, and you'll see the raw numbers and the percentages there. There is, you have 5 schools, you're going to have 5 different answers, but that's something that we're looking at, is how do we perhaps can do a better job there. All 5 medical schools, for the record, are great to work with, highly collaborative and highly communicative. The next bullet is, as Alex had mentioned earlier, the State Route 540. That was I believe the exact number was $20,007,667. That was in our amended 25 budget. That was wildly popular. That was for any program that started State Route south of State Route 540. We had like 40 different applications. Ultimately, maybe it was 38, but it was pretty much right at 40. Some institutions did multiple applications because it was driven by the program level. So like a hospital could apply for internal medicine and psych, or pediatrics and OB-GYN, or any combination thereof of any of the specialties. But we did have 10 winners. That yielded, if everything goes to the way that they represented their applications, a little over 200 net new GME slots that will come online. The bulk of that activity will occur starting in FY27 and 28. You will see of them start coming online, and then by the time we hit 29 and 30, they'll have multiple classes, and then you really start to see the wheels turning. So I do think that was, should that come back in some way, shape, or form in similar or somewhat similar format, I do think it would be well received by the hospital community. The next 2 bullets are something different. I've done, as Dr. Burke was saying, he was talking to a variety of states. I've been going around talking to a variety of states also. I used kind of the off-season between session to do that. And the good news is everyone wants to help each other. So it was good to have these conversations. One thing that has come out of it is what's called a 3+3 program. Now, what works really well right now is Mercer and MCG already do it. They have certain seats allocated where you do 3 years of medical school and then 3 years of residency. I believe it's in internal medicine or family medicine for the most part is when their students go through it, and then they're out and they're practicing and they're treating people. Perhaps considering expanded, meaning more 3+3, and I put the +2 in there because when I spoke to California, Virginia, and one other state, what really resonated, the theme I picked up with them was the +2 represents a mentorship being assigned to somebody. So you went through med school in 3 years, you went through residency in 3 years, great. Now you're out practicing. Maybe get paired up with somebody within your institution that is a little bit more senior, that can help you. That's a transition in life to go from being resident to being a practicing physician. So this would just be a way to ensure or increase the probability that that said individual can succeed in that community. So that's the +2. And then couple that with milestone-based loan repayment programs. And I'm very deliberate on milestone, meaning, as some of you all know, the Workforce Board used to do the Country Doctor Scholarship Program. That's kind of how it was known as. A lot of successes through it, but we do have a few that we're working with the AG right now to get them wound down. So maybe instead of issuing the funds while they're in medical school, there might be some payment during residency, with the majority of it coming once they're in practice. Median debt for those who report debt to us on the annual survey, we know is about $250,000 for medical school graduates. Dentists aren't too far behind. They're usually about $235,000, $240,000. So we know it's quite a bit of money. So, and then the other best practice, I learned this from New York, the NYU Grossman School of Medicine, you can come in as a first-year med student, and in your first year, you can decide, hey, I want to do this in 3 years instead of 4. It's New York, it's really expensive, so finances were definitely part of it. They can then opt to go into a 3-year format, and then NYU has what they call conditional residency in any residency, not just certain ones. So if you want to be a neurosurgeon, that was the example that I was given on my call, that's great. You just got to hit these performance standards, and then you can go into our neurosurgery program. So they're able to retain them. So these are things that are going around the country that might be worth thinking about here in Georgia. And then I'm going to transition to actually the last slide, complete pivot from the previous topic. It's just one big beautiful bill. Just some considerations of what's in it in regards to our agent, not us, our agency, but the individuals that we work with. What has changed is medical and dental professional degrees is how they've designed it or designated it. You are capped at $50,000 per year with a $200,000 lifetime borrowing limit. For reference, all the medical schools and the dental school in Georgia, the cost of attendance, so that's tuition, housing, fees, all that would all exceed $200,000. So should somebody need to go through medical or dental school 100% on loan, they would have to secure funds outside of the federal government. However that is, everyone's situation is different, but they could not do it just through the federal government anymore. And then the change for graduate nursing and allied health, it's $20,500 per academic year or $100,000 for your lifetime. No changes on undergraduate. And then you'll see on the bottom half of that slide who's in which bucket. So in the professional degrees, that's the $200,000. It's pharmacists, dentists, chiropractors, physicians, both MD, NDO, optometrists, podiatrists, and last but not least, clinical psychology. And then within the graduate nursing and allied health, it is nursing, audiologists, nurse practitioners, physician assistants, PT, speech language pathologists, and social workers. So it's impacts the, in some cases it could impact, I'm not saying it will, it might impact the full spectrum of the healthcare workforce. So those are just some considerations for y'all. And with that, I want to say thank you for your time. Thank you for inviting us here and allowing us to speak to you. And either of us would be glad to answer any questions.
Okay. Representative Hawkins?
Yeah, Chet, I really appreciate what you and your office do. A lot of good work. Let me ask you a question. On these loan repayment programs that are going to the rural areas, what % do you have to recapture? In other words, they break their agreement and decide not to go after receiving the money?
So the LRPs, we have structured it where we issue the money after they are practicing, they've validated their Alex actually does another validation, and if it's a multi-year, they have to revalidate every year before we release funds. So I don't think we've had one situation where I need to escalate it formally and try to recapture funds. We have had people through that process that say, hey, you know what, I'm changing jobs, I can't qualify anymore. They come forward honestly, and it's very easy. When I was talking about earlier of those who are non-compliant. That was the old country doctor program where they got $20,000 per year of medical school with the agreement that they would do a primary care specialty residency and then ultimately practice in a rural part of Georgia. But a lot of life can change in those 4 years of medical school, 3 or 4 years of residency, and then they decide, you know what, I don't want to be in wherever, Georgia. I want to now be a dermatologist in Nashville. That's great, but that's a broken contract, and that's okay. Many of those who acknowledge that, hey, I didn't do what I said I was going to do, they have ended up paying. There's a damages clause in all those agreements. They've paid it. We just have a few remainder right now that I'm working with the AG on to sunset those.
Small percent, very small.
Very small percent, yes.
Thank you.
Yes.
Chairman Parrish?
Thank you. Chet, thank you for a good report and the work the Workforce Board is doing over there. What specialties in residency do we not have in Georgia that maybe would cause someone to look out of state to do these specialties? Can you give us a little hint about that? What we don't have that maybe we should do so we can keep more people here?
Great question, Chair Parrish. I think we have pretty much every specialty, especially having two large programs, Emory and MCG. They have the full swath of every specialty. And then we do have, like I look at, not to select them out, but I think of Northeast Georgia, they're increasing their diversity of their offerings. I don't think it's are we missing a program at the residency level? I'm not talking the fellowship level, but maybe it's a quantity thing. Do we have enough of these seats distributed around the state? And let me go back to the SR State Route 540 program. We did the awards mainly in internal med, family med, psych, OB-GYN, I believe, were all the specialties. So that will just increase the raw count down there. But there was no like new specialty that was added through that.
What about with fellowships? Do we need to add some more fellowships that maybe we don't have or don't have enough of that might be causing some of our graduates to want to look out of state as opposed to staying here?
I would say that would be worth some research and investigation and additional conversation.
Thank you. Are there other members that have questions? I have a couple. In looking at the age of our physicians that will be retiring, what can we do? What are you hearing from residents and medical students that are graduating to entice them to want to stay in Georgia? I know you indicate the family is one of the things. I know in rural Georgia, I'm looking at some of the programs that do seem to be working and having a little bit, but what can we do? This is a big concern when we see OBGYN. We're going to need 224. How and what are we doing to entice them? What are the things they are looking for to be able to stay in Georgia?
So I do think it's a great question, Chair Taylor. I think at a high level, what is going well is that there are not just the grant recipients, but even if we go back a few years, there are a lot of newer residency programs that have come online. We actually did a retrospective analysis from 2015 to 2025 fiscal year, state fiscal year that is. Board back then was capitating about 1,500 seats per year around the state, and we are up to 2,500. And at the same time, the diversity of the offerings from the institutions have improved. I do think other things that are going on is we have the multi-year loan repayment right now for the physicians, because that's what we're looking at this through, where before $25,000 is a lot of money, but for some physicians it might not be when they come out of training. $25,000 loan repayment, but if they're getting $60,000 or $70,000 from a different hospital in a different state, they might just take that and recoup it. I do know in our survey of graduate medical education graduates, they do, it is a general theme, and say that pay sometimes in Georgia isn't as competitive. That might be a market thing. Now, they might also be looking at a higher cost of living area that I can't speak to. They might be looking at Miami, Florida, and getting 50 or 60,000 more there, but not realizing the house is going to cost them triple. So that I don't know, but I do know that that is in our survey, but maybe not as high up as fellowship and family. We at the agency also this fiscal year increased, we have in any residency program that run through the capitation payments for us, we have what we call the 5-year retention rate, and there's performance standards. If you don't meet it, there's an ability for us to reduce your payments. We took it up from 45 to never done before 55%. And largely, almost all the programs were able to still meet that threshold. So we do hope that that awareness with the 5-year rate, that perhaps allows the programs to think a little bit more about, is this person going to be here in Georgia in 5 years?
And I noticed when you discussed about dentistry, and we have so many of the corporate dentist structures now instead of individual offices, do we know why they're doing that? And could this be part of why young physicians are wanting to be more in a corporate setting? Is that part of the issue?
Corporate dentistry, there is a lot of, there's a few things, and I want to defer here to Chair Hawkins first. So before I jump into this, Representative Hawkins, why don't you tell us what you know, because I know you're close to this.
Well, not only the tuition's gone up so much, but the startup cost is extremely expensive, and the equipment, and the type of equipment they buy now, like CBCTs, cone beam machines, CAT scans, all this has risen the cost of starting a practice, typically beyond what the young graduate can even borrow. So they're either looking at joining an existing practice or this Aspen model type of thing. It's mainly pure economics is what's driving that.
Well, that's one of the things I'm wondering, does that roll over into physicians also? They may not need as many technical devices and machines, but is that part of why perhaps some of them are not staying here? Or are you seeing them into a trend of wanting to be part of a larger practice?
The trend with physicians, it's been like that for a number of years. I've worked in different markets before coming to Georgia, and Georgia probably felt this larger healthcare enterprise a little bit later than other parts of the country, but this is the trend around the country where newly minted docs, for the most part, want to go and join a large entity. It might provide them work-life balance. It might not have to be on call all the time. They might not want to deal with the admin burden of running a practice. Everyone has different preferences in terms of why. Startup costs definitely are part of it. You do have, and it is also specialty specific. If you look at internal medicine, most of the internal medicine, what we see in our data is a lot, and majority I should say, of the internal medicine graduates move on to fellowship. You either want to become a cardiologist, a pulmonologist, some sort of specialty, and then usually being within a large entity. It doesn't have to be a hospital. It could be a group of 50 physicians. I mean, it doesn't need to be, again, a huge entity, but something beyond just 1 or 2 doctors. And then with the dentists, I mean, I hear it's on the low end about $500,000 per chair, and maybe up to $1 million per chair, depending on what equipment. Do they buy it new? Do they buy it refurbed? And then they need to run at least 4 or 5 chairs to run a practice that has proper throughput for patient satisfaction and to be economically viable. So if they're looking at about $3 to $4 million on top of maybe a mortgage, dental education, undergrad, the economics are hard, and then there is a declining rate from what I read from the American Dental Association of those who, someone who's about to retire and going to pass off a practice to somebody in their family at a younger generation. That isn't happening at the same rate that it used to happen.
And one follow-up that is part of that, I guess, have we seen any movement by the tort reform that we passed this year? Do you think that will have an impact on helping us keep some of the physicians in Georgia?
It would be too early for me to make remark. I think when we do our next round of surveying in the spring, early summer, and we see those results, that would probably be the earliest I might be able to make some sort of remark off of data.
I had talked with several physicians and recent graduates. I didn't realize they even paid attention to it, but they did. So I'm hoping that that would be helpful and could be something to look at. And do you think we can fill the 200 slots? I want to make sure that if we add them, do you think there are enough folks that'll want to stay and we'll be able to get that many in a match?
Are you referring for the residency levels?
Yeah, for the residency.
I do think so. I think with all the medical schools have done a good job of in expanding enrollment. Actually, one thing that I took away from our survey when I look at the data is the increasing number of people who want to come from another state to Georgia for GME. Now, that's different than retaining them, but Georgia is still attracting people from other states. So I do believe they'll be able to fill those slots. And it's not going to come online at once. It's going to be a graduated effort over a series of 4 or 5 years in the long run.
And I noticed that the State Road 540 is letting us have more in the rural communities. Is there a way, do you think they're being incentivized? Can we earmark some of those 200 to make sure they go to rural areas? Those are one of the things that we're trying to get some of these physicians, particularly in rural Georgia.
It's an excellent observation. What we find generally, but not always, is that those who finish residency and if they do OB-GYN or IM or whatever their specialty is, and they are going into practice, not moving on to fellowship, usually those individuals end up settling and practicing within 30, 40 miles of wherever they trained. The programs, I talk to them, they all have interim reporting to us as part of this money. They also want to view this as a way, is this a physician that we want? Because there's mutual alignment here, like we want to be here, we want you to be here, and that's usually why hospitals have residencies, is to build their workforce. I do think that if that past behavior continues, which it should, you'll see additional physicians in all those communities.
We appreciate your time and effort and all the hard work. Oh, okay.
No, yes. One last thing. Your questioning made me think of something that we were talking about actually earlier this summer. The matching that goes on with the residency programs, when you're doing your survey and putting more thought into this, how about putting the thought into some kind of incentive for Georgia graduates to do a residency to try to match within our state rather than having as many out-of-state residents coming in and then losing those going back home? Maybe if we could look at it some way to increase the matching of our state medical students.
That's a good point.
Yeah, within this, yeah.
Thank you. Thank you for having me.
Thank you very much. Our next presenter will be the Office of Health Strategy. Okay, if you would introduce yourself and your team.
Yes, ma'am.
And fill us in on what you do and the services, how your agency works. Thank you.
Absolutely. I'm going to tee up Dr. Duke's fine work here in the background, and then I'll get started. Good morning, I'm Stephanie Beck. I'm the Deputy Director for the Office of Planning and Budget. The Office of Healthcare Strategy and Coordination is one of the attached agencies to Office of the Governor. I'm appearing here on behalf of OHSC this morning as their Executive Director position is currently vacant. Appreciate your time this morning for having us here. We'll do our best to be brief. We have no budget requests specific to this year. I'm joined this morning by Dr. John Duke. Dr. Duke is the director of the Georgia Tech Research Institute's Center for Health Analytics and Informatics. He's a physician as well as a research scientist. His Center for Health Analytics at GTRI is the administrator of the all-payer claims database for the state. I appreciate him being here to be my support this morning and presenting this, and I assure you he's a far more interesting speaker on this topic than I'm going to be. But after 3 years of planning and work and collaboration between GTRI, GTA, the Georgia Data Analytics Center, which is also attached to OPB, OHSC, our partners in the Department of Community Health, Madam Chair, we are now fully operational for the all-payer claims database, which is a very exciting milestone for the system. We've invested approximately $8.8 million in getting that system up and running over the last 3 years. We were able to leverage federal Medicaid dollars to maximize the state's investment into that, and that covered about 90% of the total cost of implementation. Last month, we submitted a request to CMS to receive operational funding for the ongoing needs of the database. We were approved last month, and that will then continue to leverage federal funds towards the ongoing needs of APCD, at least through federal fiscal year 2027. Right now, the system has more than 39 separate medical and dental submitting entities. They're providing quarterly data updates to the system, and that's covering about 9 million Georgians. I think we're between 70 and 80% of the population that's now reflected in the database. We're collecting more than 200 million individual claims per year, and we have a database that houses more than 1.4 billion claims records in total at this point. So even though APCD has been in its development phase over the last 3 years, the Center for Health Analytics has already completed 19 use cases, and they've used those to develop public interactive dashboards and reports looking at topics like rural and urban access to health care, chronic disease prevalence in Georgians, mental health in youth, our infant health, and then cost of care across providers. Dr. Duke is going to speak to some of those more specific cases that GTRI has been working on, but it's an exciting time for the system. We're seeing increased interest from external entities in accessing the database for their research. We've approved 10 external applications to date for use cases outside of GTRI. We're also providing other state agencies a valuable resource in conducting their work. We work with the Office of the Commissioner of Insurance on the surprise medical billings oversight. DCH plans to use the database to do some of their market comparisons and rate setting for Medicaid and Medicare. And then DPH is able to utilize the database for things like maternal health, epidemiology, public disease surveillance, et cetera. And then, first and foremost, we have a responsibility to the taxpayers to use the database to inform their health decisions. And Dr. Duke can show one of the dashboards that they've released recently that does help the individual consumer make more informed choices about the financial costs of their health care, be able to compare rates for certain procedures between hospitals. So there is a lot of publicly available information that's very useful for the everyday consumer as well. So with that, I was going to turn it over to Dr. Duke to give a demonstration of a few of those use cases, if that would be okay.
Well, thank you all very much for having me, and thank you for your support and guidance around the all-payer claims database. I think Georgia has very quickly moved into the ranks of one of the most recognized across the country for the work that's been done with the Georgia APCD. I'm here on the Georgia APCD website. We try to make the acronym pretty easy to get here. It's apcd.georgia.gov. And as mentioned, we have a lot of use cases that we've completed over the past couple of years. But I think most notably, I just wanted to be sure that folks knew where to go from the very front of the page. Hitting information on data and reports will tell you about how to access APCD data, the types of data that are in the all-payer claims database, the individuals covered, as well as a pretty quick way to get and look at public data that have been released. But if any of the organizations, agencies represented here, or colleagues have an interest in utilizing the APCD, there's a very well-formed process to go through and request data to be able to conduct. Now, we've done a number of use cases covering a wide range of areas. One of the ones that's just come out that I think might be interest in terms of particularly expenditures is this cost comparison tool. And I'll go ahead and click on this example here and maybe show one other one if we have a moment. We do put some information about the methodology. Doing cost analyses, as Chairwoman knows well, is very, very complicated for a lot of reasons. But we try to be very clear about what we did. Also, that we've brought in CMS, Medicare, Medicaid's facility ratings, which we did not develop, but it's a national survey. And so when you look at the dashboard that we have here, this is a dashboard looking at what the negotiated, not negotiated, I'm sorry, the sort of submitter allowed amounts are for different conditions or procedures. So for example, I'm going to look at surgical procedures, and I'm going to go down to hip replacement here, and what we'll notice, I'm going to start with Medicare. And the reason I'm starting with Medicare is you can see that the sort of pricing of a hip replacement with Medicare is relatively tight. Typically, the costs are pretty well specified, and you can see that the sort of median rates. And if you're wondering, what am I seeing here, you can actually pick your zip code, and you can say, I want to look within 25 miles, I want to look within 50 miles, I want to look within 300 miles, or as much data as we have in Georgia. So if I kind of extend this out a little bit, we can see a map of Georgia here as well, and I can quickly see how many patients have received this procedure at this particular location under Medicaid, which is the category we're in right now, what the median cost was, what the lower percentage cost was. Things get, of course, more varied when you look at commercial costs. So if we look at commercial payment, that's going to see a lot more variation across the hospitals, and we can see this is by distance. I'm kind of an alphabetical guy. My team really likes distance, so, but I'm going to it's easier for me to look at it this way, but you can see what are the costs at different centers for these procedures and so forth, and what they range. Now, if we were to look at something different, say, for example, we wanted to look at delivery for a new infant, we can look at, I'm going to look at a cesarean delivery without complications or comorbidities, and again, we can see what the ranges of different costs within particular areas. We can again look across the whole state. You can set your starting place to any zip code within the state and see what those costs are, see what they represent, and then again, these facility ratings come from Medicaid, from CMS, Medicare, national. It's not done at the state level, and it's for the facilities. You can also do a little bit of evaluation and just kind of see, does this make sense logically? If we go to Medicare, what we'll see is hopefully there's no matching, because it would be unexpected to have a cesarean delivery by someone on Medicare. So we have lots of Medicare data for some categories and not for others. This has just come out about 2 weeks ago. We look forward to welcoming feedback. We're continually adopting and adjusting to enhance the usability of this system. So please take a look and provide feedback. We would love to hear your thoughts on that. And I'll just point out one other one, and then let the committee sort of return to questions. But that's our Condition Explorer dashboard. This dashboard looks at chronic and some acute disease across the state of Georgia. You can actually look at, so kind of going back, whether you want to look at specific counties or whether you want to break it down by other demographic information. You can say, well, I'm interested in hypertension, or of course, diabetes is one that we very commonly might look at. This gives you a breakdown across the state in terms of the rates and where the levels are higher. But one of the things that you can look at is actual medical costs as well. So we can sort of see what are the cost details for patients with diabetes or hypertension or hip replacement, et cetera. And we can look at what is the cost specific to that condition, what is the cost specific or overall care for those persons, and we can really group it in lots of interesting ways, looking by region, looking by, so looking at, for example, different parts of the state and how it varies, looking across counties, looking at urban-rural variations. And so this is just one of the dashboards that really help you better understand both the nature of conditions across the state, as well as the nature of how we in Georgia are seeing those costs vary. So it's, I believe, complementary to many of the other categories we have here. So thank you very much.
Does anyone on the committee have questions? Are you complete?
Yes.
I have questions.
Yes, of course.
Okay. Lee, did you have a question? Yeah. Please, go right ahead.
Okay, excuse me. I was just on my phone going to your website. It's very impressive. You all have done a lot of hard work here. But maybe it's different on the computer. When I go to the phone, I'm not seeing some of the sideline information that's coming up on your slides. Is that because of my phone?
If you look at the dashboard, so the data, we have many reports and things like that, but the dashboards are not too mobile friendly due to just the technology, what's called Tableau, the visualization, so they're not as handy, but you should be able to see all of these categories here. So if you look at APCD and click on data or over at the top, public data, hopefully all of these are showing up.
Still very impressive. A lot of work. Thank you.
Thank you.
Yes, this is a lot of information. Is it complete? Do we have all the payers in there? Is everybody contributing the data?
Thank you. So the payers for those over 1,000 patients in Georgia who have not had some burden or threshold for which it's been determined that they're not do not need to submit, that is complete. Of course, federal or Supreme Court guidelines said that ERISA plans, self-insured employers are not mandated to submit, but in terms of required submitters, we do have that complete.
Okay. And do we know right now who is using it, who's utilizing all this data? It's great data. I'm a data person, so it's a lot of good information. Who is it available to publicly, and are private entities using it?
Yeah, so we've had a lot of engagement with many of the individuals here in this room who have presented earlier today, DCH, DPH, Healthcare Workforce, Office Commissioner on Insurance. We have had a lot of engagement with the state, but also with the universities. We've had all of the universities, not just those with medical schools, but across the board, have engaged with us about access. We also have nonprofit organizations looking to better understand the healthcare within cities, for example, the city of Atlanta. So we've had a really wide range. We also look at access or traffic to the website to try to get a sense. We're not doing kind of deep analytics in terms of their intentions, but we know that there's been a good amount of traffic, and we continue to try to communicate and advocate. So I would say it's a good mix between researchers. I think this dashboard on cost is really the first one that's truly consumer focused. We have ones, access to care, that are very interested from a policy perspective, from a research perspective, but I think this is our first push towards consumers. So we'll see how that goes, and if we can be successful in bringing kind of everyday Georgians, which really is the intention, in addition to policymakers and regulators and researchers.
I'm looking for how we can do more with it. Mm-hmm. Are we identifying maybe preventive, or in a certain area where we're seeing a cluster of a particular diagnosis? Are we looking at any of that?
So yes, absolutely. We have a couple big, I think, highlights that are reflected here that I won't walk through, but I'll mention. One is we've looked at the change, looking at pediatric, basically from 0 to 26, mental and behavioral health over the last 7 years, and looking at the patterns across a wide range of conditions that are of very great interest, and looking at how those rates have increased, how they've leveled off, and where they've actually continued to go up after COVID. This report on here, it's called Mental Health in Youth, is really extremely eye-opening. That one is focused on overall patterns. The Condition Explorer and the Healthcare Access will give you information about specific conditions and where there's gaps I think, as mentioned, we've thought about workforce and worked with that team. One of our questions is, what are the services that people are leaving their county for, and services that are being provided in that county, and where is that imbalance? So a lot of our work is kind of essentially forming this kind of surplus or deficit of care supply within regions, the distance to travel. So if you go to our workforce dashboard, which is basically focused on the level of distance to care, the provider of that specialty in all of these different counties, you can go a little bit deeper into that, and I think we've highlighted where those gaps are. We're also building tools that let you simulate or model if I added a new hospital here, if I added a new set of services, an emergency department, how might that affect the provision of care? And so that's one of the uses that the APCD sort of research side has enabled exploring those. And we would be very eager to hear some of the policy questions that people are considering, and if we can inform them. The GLP-1, at about 10:15 this morning, I wrote my team. I said, hey, team, can y'all get me the answers to what is the percentage of GLP-1 users who are diabetic? What is the demographic breakdown? And I said I would need it by noon, and we came up slightly earlier than I expected, so it might be in my pocket right now, but I will get you the answers to your questions for sure by the end of the day. And that's the kind of responsiveness that I think you can get with the APCD data.
Thank you. Chairman Hatchett has a question.
Thank you, Chair Lady. I think you touched on it, but I don't know if you went totally into the details. What organizations or who is actually reporting data to you? Where are you getting all the data?
We have a list of submitters that's about 60...
A little over 50.
A little over 50 payers, and some are quite large, and they sort of dominate, of course, but we have data from Medicaid, from Medicare, from the commercial payers.
State Health Benefit Plan?
State Health Benefit Plan, yep. Mm-hmm. So it is, it's a list of about 50, but we can get that to you, yeah.
This is all very impressive, and I want to throw something out there to you. As important, the cost alone is very important, and that's what this is derived to do. Is there a way to get with some folks and consider expanding it to have outcomes? That is one of the things I think that at some point in time we need to be able to tie outcomes to not just costs. And when you look at costs, sometimes it could be a secondary payer. Do you identify if it's a secondary payer? Things like that. And to me, to make it complete, we need to be able to tie it to outcomes. The hospital might be the cheapest, but it may have infections or complications or readmissions. I know that's futuristic, but is there a way at some future time to be able to look at those type of attachments to the system?
Sure. I mean, I think that's at the heart of it, and some of it we can do today, extrapolating from claims. For example, looking if someone had back pain, do they go on to have physical therapy? Do they go on to have back surgery? If they go on to have physical therapy, are they getting opiates? How do they? So we are able to use claims to look at some outcomes. But you're absolutely right that some of them, what is the laboratory result? What is the hemoglobin A1C for a diabetic? What might be a radiology report? That's information that would be coming from clinical sources. So we do believe there are pathways to make those connections, but I definitely want to assure you that even now with the claims data, we can look at a number of sort of outcomes in a sense based on kind of national approaches and methods for making those determinations.
Well, because of HIPAA, it is de-identified, but you do have a way internally to know claimant number one was seen 6 months later. It's still...
Absolutely. The longitudinal, in fact, one of the great things about the APCD, more than I'd say any other data set in Georgia, is it crosses. You can change payers, you can change hospitals, you can go, and it will be able to track that entire longitudinal course, which is really important.
I think it could also be very helpful with CON to see how many people from a region are leaving this area to get extra care. Or okay. I don't see any other questions. Oh, okay. Representative Seaball.
Thank you. This is good information. Do you talk with any of the Georgia has a number of registries: cardiac registry, STEMI registry, Coverdale Stroke Registry. Do you talk with them? Will that ever become a part of what you do here?
So absolutely we do. The first one, probably not surprising, is the cancer registry, and looking specifically at whether we can help inform or work together so that we can do a better job kind of enabling the registries to see the care that happens across all the different sites. Those typically happen via inbound questions. We try to make the APCD known to researchers, and then they'll kind of reach out. But I think that registries are a particular advantage for kind of this connection. And so we started with oncology, but I do think it could be expanded to look at cardiology or other areas.
Thank you.
Thank you very much for your presentation. We appreciate all your hard work. Thank you.
Thank you.
We are making great time today. We are going to take a break for lunch right now, and we'll be back at 12:30. Thank you.